Okay, great. So, Julio, thank you so much for the honor of being a part of this meeting. And I just want to say thank you really to Thomas, Luis, and Claudio. Those are really great talks. And I just thank you so much for sharing your ideas and concepts with me. Thank you. Okay, so under deep gluteal syndrome, my disclosures, I'm consultant with Smith & Nephew. I was with Pivot. And the Baylor, this doesn't reflect the Baylor policies. We're going to talk about the concept of DGS and one of the more common causes, and then where are we today with this? Just any entrapment of the branches that make up the sciatic nerve in the pelvis or in the extra pelvis. It really is dependent upon the layers of the hip. Like we've always said, everything is really dependent upon the osseous, the capsulolabral, the musculotendinous, the neurovascular, and the kinematic chain. But I'm even more convinced after having done this almost 20 years that we have to fix the bone first. We have to be aware of all the causes of impinging abnormal biomechanics in the hip and because of the osseous three-dimensional abnormalities that can affect each of these layers upstream and all the way up into the spine. And I think it's now time that we have to be aware of the effects that the hip has upon the spine and the pelvis and the core, and our scores should reflect that. So the kinematic chain is just really what's happening from these premature coupling abnormalities that can occur inside the hip socket through torsion, through cam, through pincer, through deformities of the femoral head. So what are the causes really of posterior hip pain, and how do we sort this out? Well, there's some primary causes of deep gluteal syndrome that can be in the pelvis or they can be extra pelvis. They can be secondary due to limitations in hip extension or secondary to hip flexion abnormalities such as cam, or it can be a combination problem. These can be torsionally related as well. They can be affected through the ischial-femoral impingement, greater trochanteric impingement. Hamstring tears can also grab the sciatic nerve through chronic tearing and healing. This can affect the interconnection of the pelvis as it's prematurely coupled, can also affect some of the kinematics of the pudendal nerve and its coursing across the sacrospinous. The cluneal nerves can be involved. We can have intermittent gluteal claudications, posterior hip joint abnormalities, sacroiliac joints, primary or lumbar spine pathology. So how do we sort these things out? Well, we have to sort from the top. If the hip's generating, we still have to start at the spine and see what's entrapping. So we have to rule and clear the spine first. We have to know that there's sacral pathologies that can involve the nerve roots and give you posterior hip pain. This can occur with intrapelvic entrapment through a host of different etiologies, but it could also be entrapped through extrapelvic. So those are on the primary entrapment types of location. Then we have the secondary. The secondary are really what's causing the piriformis to go into spasm or to grab the nerve prematurely. And these can involve the extension blocks associated with IFI, decreased or increased torsion or profunda. And then we can also talk about cam impingement for its induction of secondary piriformis pain. And a lot of the patients have both. So we have to classify in DGS, is it a primary problem or secondary? Because if we try to fix a cam and we don't be fully aware that the posterior is involved, or it could be a primary lesion in the posterior side, we can do a disservice, and the patient will have a revision, or they'll wind up in a spine service or a pain clinic. So we can clear, this was a laminectomy done for a disc hernia. We have to make sure that we need to make sure that we look proximal and distal to the sources. The very first division in the tree of assessment really is intrapelvic versus extrapelvic DGS. This is an intrapelvic lesion. An ovarian cyst, the cyclic pain can come and go. They can present with posterior hip pain. It's just at the same time every month. It can also be vascular. The vascular pain can be worse whenever sitting up, and it's alleviated when laying down on a contralateral side. Those are two different causes. We can have some abnormality, up to 17% have a split piriformis that goes inside the pelvis. Well, if it's muscle, it can be stretched, it can be Botoxed, it can be treated. If it's tendinous, it's much more difficult to be able to do that. So it can be either primary or secondary. Now we move on to the extrapelvic. Extrapelvic can be a result of trauma. This is just a classic horse strap, as described by Luis Perez and Caro, and here as this scar band is tethering the sciatic nerve at 90 degrees. We can tolerate tethers of the sciatic nerve up to 45 degrees, but when they're tethered at 90, there's no way for that nerve to spin. They can be also extrapelvic can be involved with hamstring or chronic hamstring tears. So that's hamstring syndrome. And they can also compress the sciatic nerve due to musculotendinous. It can be osseous. This is an osseous lesion here that we can see, and this is an old slide that you can see on the posterior edge of the greater trochanter. This is in deep flexion, abduction, external rotation of the hip. But if they have dysmorphism, or you put the prosthesis in a bad place, which we've seen many times, sometimes the sciatic nerve will be directly impinged into this area at the greater troch as well as at the lesser trochanteric area. You can document that. This is a case of extrapelvic greater trochanteric sciatic impingement with a snapping posterior nerve. This was a retired professor from a university, and she had a very difficult retirement, even being able to sit in any capacity because of this snapping sciatic pain in her posterior hip. Varices or veins can fill up and place pressure over the nerve. And again, that's got a very typical history of pain only with sitting, no pain alleviated lying down on the contralateral side. And it's a crescendo pain that builds up through the days. So in intrapelvic types, we have to be aware that these are fluctuating through the history, the menstrual cycle that can be painful with intercourse, and the positioning. So the piriformis can be affected with both types of abnormality. So if the piriformis has something laying directly on it, such as this mass or uterus, you can see that it'll come and go within each month. If you can look down there below, there's a bicornate appearance of the uterus with venous congestion. The branches overlying basically all 5 S1 regions. At the bottom, you can see the hamstring and how it's crushed by IFI, by ischiofemoral impingement. Here's some sacral tarlobs. So it can be inside the sacrum as well. Typically, tarlobs are asymptomatic, but sometimes they can be so large that they can put pressure into that area. You can help to sort that out through your history and physical examination as well. Sometimes these things are symptomatic and sometimes not. It can be a space-occupying lesion, such as this osteoid osteoma. How do we sort it out? We do it through the physical examination as well as CT-guided nerve root blocks to help identify the symptoms. Tractography, as Nusalio Lemos has been working on, can help you to identify, here's an extrapelvic source of sciatic entrapment, and be able to separate it from the intrapelvis. So the sources of an etiology either can be proximal or to distal. So epidural steroids, transforaminal neural blocks can be correlated, but here are just some pathologies that can be associated with intrapelvic types of secondary piriformis or DGS. We don't like to see the piriformis go all the way up into that nerve root like where the arrows are pointing. We like them more on the outside. Here's just the way that the branches come off normally. There should be some nice fat around the nerve, but when the fat is all lost from these varicosities, you can have the posterior hip pain. So steps in consideration of DGS, it's really through the history and physical examination, get a good history and physical exam, do your injection testings, make sure that we look at the imaging. I like to use a 3T MRI with very small cuts. We always do a good physical therapy, no rehab program, and then we can make sure that we get into the area to make the proper diagnosis. So what about secondary? What's this secondary deep gluteal syndrome? Sometimes I think we fix this. We've been fixing it with total hips for a long time when we have unexplained posterior hip pain, but we can also be aware of the causes of secondary SI joint pain and the piriformis attempting to spasm. Just like we have in the front with the psoas, we can have the same thing in the posterior aspect of the hip. Well, what's going on here? Well, we look at the distance, really. It's about the femur and the pelvis. We have a very short lever arm and a very long lever. There's huge amounts of force that are being generated through the hip socket itself. And when those prematurely couple and abnormal motion occurs, these secondary strain parameters produce other upstream or downstream injuries, such as limited internal rotation through torsion, through cam, through pincer, and that can be related to core injury. We can look here also with limited flexion extension can create low back pain. This has been well documented through history. We have to, as hip surgeons, be aware, I think, of our influence on spine disease. Why do we need to do it? We need to do it because it helps the patient, and secondarily, we can avoid a lot of unnecessary spine and pain referrals if we're aware of the hip's influence on the lumbar spine through all of these pathologies. And it can be associated here not only with hip extension or flexion deficit, it can be also associated with decrease in internal rotation. Even distally can be associated with ACL. So why does this have to do with DGS? Well, the strain is going proximally. The piriformis is tensioning, trying to hold everything, just like the psoas does in the front for an anterolateral tear instability. And so both these premature couplings and flexion extension can produce this abnormal strain and the secondary response. So the etiologies of secondary DGS, according to abnormality, really includes anything that causes hip limitational extension. The most important is if you have excessive femoral anteversion, it hits the back wall. With decreased torsion, it's through the premature screw-home mechanism of the ischiofemoral ligament and the iliofemoral ligament. You can have posterior overcoverage, like with a profunda. You can have a big cam on the posterior wall, like somebody famous we know. There can be some capsular contracture, but these are really sorted out through the physical examination and really split out quite easily through a good comprehensive exam. What about flexion, hip flexion limitations? We know these. I'm not going to go through them. You can have combinations of these problems. This is one of the first cases. This lady has Ehlers-Danlos. But as you can see, she prematurely couples at a -20. You abduct and you can take her into terminal hip extension. She has definitive ischiofemoral impingement. There's no torsional effect with that. But she presented with a piriformis problem. It's really a secondary to this. I taught her how to walk with either short steps or wide steps, and her piriformis sometimes went away with the rehab because she had no cam, no morphology inside. Secondary, again, here can occur through ischiofemoral impingement where the piriformis is trying to stabilize the pelvis. So what do? We treat the bone first, and then you can treat the piriformis through injection, rehab therapy, and combinations. We began to look at this combination of how the hip was affecting the spine when we did this biomechanics study, and it showed that we did have the secondary load transfer even upstream into the facets. But I think by noting that, we can avoid these type of complications where this lady had 20 prior spine surgeries for ischiofemoral impingement bilaterally. And I have to say that we just got her 2-year outcomes, and her hip score went to the 95s, and where she started with 68 on her Oswestry score, she was in the 20s. So made a big improvement for her life to fix that. Let's talk about torsional anomalies, which look the same. Can't get your hip into extension, but what is this? Well, this one is decreased femoral torsion. So you just terminally, we release the ligaments by doing that, and it allows the ischiofem and the iliofem to be able to release. So it's like doing a Mackay when you fix it with a torsion. We have to, in the laboratory, we also were able to affect the facet loads with this. The posterior wall can present similarly, but not exactly the same. What about increased femoral torsion? What's going on here? Why can't she get her hip into extension? Well, all you got to do is turn it and put it back in the socket, and there it goes back, and all of her piriformis and butt pain is completely resolved now. And I said, is the pain there over the piriformis, and then is it gone when we do that? She gave me the affirmative. So what about flexion? This is the way we can pick up decreased femoral torsion. Here's the same thing on a flexion coupling, premature coupling. When we flex up, she's presenting with SI joint, posterior hip pain. But when we do her pain, and she has no pain even though she's got a cam and pincer anteriorly. It's all posterior. But if you bring her up right there, it reproduces her SI joint and her piriformis pain. And if we bring her back down here again, we can repeat the same examination, slightly externally rotate her, and then bring her up into terminal flexion, and alleviates all of her pain. She has no more pain with the same motion, correcting the torsional anomaly. So we just have to be aware of decreased femoral torsion at both flexion. This is what happens in the cadaver lab. We demonstrated that you have a 30% increase in interdiscal pressure with the presence of CAM using Birmingham's method when recreating in the laboratory. So how do we diagnose? Well, you got to look at all 5 layers in order to treat this 4th layer. The 4th layer follows the first, the second, the third. We have to be aware of these and try to treat them the best we can in a sequential manner, beginning with layer 1 and understanding the pathology that's being generated from that area. So the key is critical. Make sure that we do this comprehensive history and physical examination, understanding mind, body, and spirit, because these people are very psychologically impaired because they can't walk, they can't sit, and they've been cast off for this deformity, and they may present with multiple different layers of pathology, but it's all related to the osseous. So they're sometimes pretty frustrated. And it's been a big difference for us to have the mental component of these patients assessed prior to because they need to understand this is a hip disease problem and it has to be treated for a lifetime. So meaning that they have a part to do and we have a part to do with them. So again, just the 3T, make sure that you understand the differentiation for pudendal hamstring tears, ischiofemoral impingement, and DGS. And the physical examination tests, I've been through this before, I think, but I'll show you the pictures of each of these tests. We begin with the gait, but not only gait, we like to see if we can accentuate the pain by internally or externally rotating the foot. If we can get rid, or abduction. If it's abduction, it can be related to ischiofem and terminal hip extension. If it's with internal or external rotation, it can be torsionally manipulated. The pain or the resultant pain can be torsionally related. So we need to start with an oswestry, find out exactly where the posterior hip pain is located. Always screen the back through forward bending, side bending on both ways. Look at the location of the pain. The differentiation here is in terminal hip extension with Edna and A, and in B, it's heel strike. B is going to be more the hamstring, and A is going to be in terminal hip extension associated with ischiofemoral impingement. So do a good neurologic examination, check the sensitivity of each of the dermatones, and do a straight leg raise is what we're doing in the bottom to make sure that we don't have a back problem. I also have now included a slump test to make sure that the patient doesn't have still lumbar spine. Check the internal rotation. We should have 20 degrees of internal rotation. That's important for just terminal hip extension, and 45 degrees of external. Correlate that to your gait study to pick up increase and decrease along with your prone test, version test. So I do also palpation. Is the pain medial? Is it related to the pudendal? Is it on the hamstrings or lateral? Is it the semimembranosus? Is it the semitendinosus, or is it just purely lateral? You can separate these out with piriformis tests. When done in combination, they have a high sensitivity, either passively or actively. The passive test is left, the active test is right, and holding it for 30 seconds in both ways. We can do an active hamstring test both at 30 degrees and at 90. That has, for us, a good sensitivity. And if it recreates the sciatic complaint, that's a hamstring syndrome, and that's the location. Again, the hip spine flexion test is just seeing if the spine prematurely couples with the flexion, adduction, internal rotation test and recreates the low back pain and hip pain. This has been a big breakthrough for me. This is from Nusolio Limos. Check each of the dermatome distributions from S1, S2, and S3. Do a stroke test on each of these dermatomes and compare side to side. This is going to get more your nerve roots in the interpelvis or sacrum. If they're more down in this area, you know it's going to be more into the extra pelvic region because it's in a different location. It can't be up that high. And that's really helped me. And you can do this provocatively, help to sort out the inter versus the extra pelvic locations. In radiographs, I left Moon of Sin, it's in Portuguese, but you can see there it's the same. Make sure you just have a sequential radiographic assessment, going through and each systematically, each detail, because it does affect your recommendations to the patient. You know, the IFI, posterior wall here, femoral neck version, all of these things are important, leg length, and assessing the overall biomechanics of the patient. So make sure you go through that step sequence. In MRI as well, posterior wall can be overcovered for a block of terminal hip extension. In MRI, we use a sequence as well, how we work through the patients, looking first at the axial, then the coronal, the sagittal, and then with the supine. So if you go through it that way, every time you'll be able to do it. But most importantly, to do a functional MRI, this is how we do it. And I think that this has increased our ICCs, interclass correlations, and how it's helped us to understand this pathology. So we have the patient walk, we measure that distance, we tape the patient's feet in the position walking, whether it's internal or external, and they're taped in that position, and that gives us an assessment a midfoot stance phase. That midfoot stance phase is critical for the determination of looking at your IFI and your femoral torsion. So it's a very, for us, have been a very, we have a very small range when we do it with this methodic method. It's called a functional MRI, meaning it's not really functional. It's just a static MRI taped in a consistent method every single time. And as we've taught our radiology techs to do it, and it's been really helpful for us. And this is a way, of course, you can always check your femoral torsion. The way I do it's go to 0, either add or subtract based upon the knees. Always take the knees first, either add to 0, whether that means adding or subtracting, and then you can add that to the femoral neck torsion to be able to get it. We have to know this because sometimes we induce a lot of back pain when we malalign our prosthesis. And then the patients come to me with an anterior hip, total hip with posterior hip pain, but it's just torsionally malaligned. We've got the cup in 40 degrees or the stem is in 35 and the combination doesn't allow terminal hip extension, and they're dying with torsional malalignment. And so treatment of DGS, really, we always start with physical therapy, injections. We start with CT-guided piriformis Marcaine steroid. Then we go to Botox if we have to. You can do a peritrochanteric branch to detect some of these scar bands and just do a high volume peritrochanteric space injection. If that gets rid of the pain and Ober's is gone, all the radicular complaint is gone, it's an extra-articular component of entrapment. So but the main thing, I put this in red, we want to treat the osseous layer first. For torsional, if it's a female, if anything less than 0, I'm worried about how they're going to do. If they're anything greater than 30 degrees torsionally, I'm worried about how they're going to do, because that in the cadaver lab really affects the kinematics in a way that the lumbar spine and compensatory strain moves upstream and downstream. Now, I don't have enough time to go through that today, but it's what we see in the clinical, and we see it in the laboratory. So, but treat the bones and have a plan, treat the capsulabrum, be aware of the musculotendinous through therapy, but know their effect on the nerves, and then just have the patient understand these are the layers of the hip, and these are the way things have been affected. So we have a plan for the patient on every single time. We can avoid a lot of surgery, but when we have to, we either have open or endoscopic. Open's been around forever. It's had good outcomes. This is how we do it. We go with the posterior lateral corner for anything complicated. We use neural monitoring today, especially with this and not in arthroscopy, because you can see here, it's a lot harder to see things. See, everything is red versus the endoscopic technique. You can see how you can perfectly see everything, what's nerve, what's not, and much more able for better visualization with the endoscopic. This is just, and we tend to use the endoscopic for things that we think are simple pathology detected on MRI. If they're very complicated, like large varices or something like that, then they have to be opened to be decompressed. So just again, in sorting posterior hip pathologies, there's a primary and then there's secondary. There's intrapelvic and then there's extrapelvic. How do you differentiate it? You do a good physical examination, a good history, a good physical examination, use a standard radiographs, an MRI, 3T pelvis, check all 3 planes, always screen the lumbar spine to make sure that that's not involved. And then be aware that torsional influences, if you're too far outside, if your McKibben's index is too far out of either direction, either retroverted or excessively anteverted, there's extra-articular impingement or extra and intra-articular impingement, which can truly affect your piriformis, just like it does on the psoas on the anterior side. We've just reported our torsional study looking at what's happened to our spine scores. I reported on it at issue, but we just completed the study. Both have been accepted for publication. And the improvement that we found were on the femoral derotational osteotomies. We improved the modified Harris-Hiff score from 58 to 82 alone with no scope. Some with scope, but mostly without. And osteoarthritis from 45% spine impairment to 22. And with lesser trochoplasty held up with about the same numbers. So I think that we have to be aware that premature coupling is bad for everything. Each layer of the hip gets affected by abnormal osseous biomechanics, and we have to be aware of all of them. So we do that through good history and physical examination, try to maintain a sequence of injection and PT for therapy. But we get by with a lot of avoidance of surgery by teaching the patient how to avoid the impingement through changing the rotation of their gait. And some people can modify, some people are not able to do it, but that's where we always start. But correct the biomechanics through leg lengths, hyperpronation, every aspect of it that you can. And then good strengthening for abductor strength, and see if you can maintain the normal kinematics of terminal hip extension and flexion. If we can do that, we can avoid the surgery altogether. If not, Botox, piriformis injection, and for those cases that fail, we'll have to do either open or endoscopic, but that's only after the bones have been addressed. So thank you guys.